Hi everyone, hello. Thanks very much for the invitation to come and speak. So I'm not a nurse, but as a social worker, I think I share some of the kind of aims that you will have to try and increase the opportunities for involvement in research and to foster a research culture among all the professions in mental health care. And so it's fantastic to come here today. I've had a really good day hearing about all the fantastic work that is going on, and a real chance to sort of get new ideas and meet people and hear new things. So thanks for that. So I'm going to talk about mental health crisis care now, and in all the sort of slew of kind of policy guidance and initiatives that have come out about crisis care in the last couple of years, I think the single thing that's probably sort of stayed with me most is from last year's Care Quality Commission report, Right Here, Right Now, where they surveyed people who'd used crisis services, and only 14% of people said they felt they'd had the right care from mental health services during a crisis. So I guess when kind of as researchers or policymakers or whoever, we lapse into sort of more abstract terms about implementation and quality indicators, it's worth keeping in mind that that's what we're talking about still really, is this sort of duty we all have really to try and provide help that is really, care that's really perceived as helpful and supportive by people, and particularly at times of crisis when people are at their most vulnerable. Okay, so specifically I'm going to talk today about crisis resolution teams. So this is only one part of crisis care in mental health, but an important part. So crisis teams exist in all mental health trusts and have done for about 15 years now. So apologies to those who know them as home treatment teams or crisis assessment teams or intensive teams rather than crisis resolution teams. CRT for that is the jargon that I will probably end up using today. Basically what we're talking about though is community-based teams which provide intensive home treatment over a brief period to try and provide an alternative to hospital admission for people during a mental health crisis. And all the work I'm going to talk about today is largely informed by a study I've been involved with over 6 years at UCL, now the core study. And that's come in sort of 3 phases, so it's been quite a chunk of my life really. But the first thing we did was try to gather together all the evidence we had about how crisis resolution teams can work as effectively as possible. So what we know from previous research, we surveyed crisis teams and asked the managers how their teams worked and what they thought was important. And we talked to people who have used teams and worked in teams and worked with them. And from all that, we tried to put together a kind of really clearly defined model of good practice of what a really good crisis team should look like. And we developed this thing called a fidelity scale to try and be able to go into teams and assess how far they're achieving this kind of model of best practice that we've put together. And we used that in a survey across the country of 75 crisis teams. And that gave us a really good national picture of how things are. And it was also a real opportunity to see wherever teams were doing things well and to make a note of that. And we've tried to draw on that in the last stage of the study, which was to develop a sort of set of resources to help with service improvement in crisis teams. And I'll talk a little bit more about that later on, but we put that together and we've tried it out now in a cluster randomized trial, so 15 teams getting this period of support over a year and 10 teams as controls. We're just coming to the end of that work now. I'm afraid I don't have the results to share with you. They'll be available later this year, but they're coming soon. And I just wanted to acknowledge really that all the work I'm going to talk about has been a big effort over 6 years involving a ton of people. So this is some of the people who have been mainly involved, but there are more as well in all the services we've been to who have helped us a lot. Studies led by my colleague Sonia Johnson at UCL, but a really sort of big enterprise. So because I don't have the results from the final trial today, I'm going to try and not do that thing of going blow by blow through the study we've done and then end triumphantly on results will follow next year or something. But I will try and draw on the work that we've done and pull together everything we've had to answer 3 questions that hopefully are useful for people working in practice and in research. So the first one is a fairly fundamental one. Are crisis teams actually an effective service model? If so, what are the kind of critical ingredients of a good crisis team that helps it work as effectively as possible? And then crucially, how can crisis teams be supported to be the best teams they can possibly be and to provide the best service possible for people during crises? Okay, so are crisis teams an effective service model? Well, we've only had one randomized trial in the UK of a modern crisis resolution team, and that was by Sonia Johnson and our colleagues at UCL about 10 years ago in the North Islington crisis team. And I think it's not too surprising to realize why there might only have been one. The sort of challenges of randomizing people at a point of crisis, both ethically and practically, are large. But that had some really promising results. And what they found was that when people were offered access to the crisis team as one of the options for acute care, that did, sure enough, lead to a reduction in admissions and a greater satisfaction for people with the crisis care on offer generally, compared to people who weren't offered that. And that's been corroborated by previous studies, sort of a longer time ago in North America and Australia, of fairly similar services, and the Murphy review pulled all that together. So from the most robust evidence we've got from trials, we've got good evidence that crisis teams can be a really helpful service model that both reduces admissions and increases satisfaction with care. And in England, that was kind of corroborated and confirmed by a kind of national scale service evaluation conducted by Giles Glover and colleagues at the time when crisis teams were being set up across the country. So that was a real opportunity. And what Glover and colleagues looked at was, when a crisis team is set up in a particular area, in a particular trust, what happens to the admission rate in that area? And they found that, sure enough, in general and on average, there was a kind of reduction in admissions in about the order of 20% when a crisis team was set up. So some really kind of nice evidence that actually in practice these things seem to be working to reduce admissions as well. There's always a but, isn't there? So I'm going to just talk about some of the buts now. So what Giles Glover and colleagues also found was, although on average teams reduced admissions, how much that happened varied enormously. So some teams seemed to have a really big impact on local admission rates, and other teams none at all. There's also been a kind of reanalysis of that data, and I think one of the things that complicates the picture is that actually inpatient bed use and admission rates have been falling in the UK since the 60s. The sort of big old hospitals have been closing. There are fewer and fewer. And what tended to happen when crisis teams were set up was that local acute beds also got cut. And it's pretty hard to tease out what's going on there. Actually, is it just cutting acute beds, which is the crucial thing for reducing admissions, rather than having the crisis team as well? So that was the argument of Jacobs and Brynmor. One thing that I think we do know for sure is that despite the introduction of crisis teams and a proliferation really of kind of less restrictive alternatives to hospital admission, so crisis houses, crisis cafes are the new thing that seems to be coming out there. But despite all these, over the last 10, 15 years, rates of compulsory admissions in England have continued to rise year on year. They're already high compared to most of the rest of Europe, and they're going up. So our mental health crisis care is becoming more coercive year on year at the moment, and crisis resolution teams don't seem to be doing much to touch that. We also looked at an early part of our study at what more non-randomized, sort of naturalistic evaluations of crisis teams have found. And that's the systematic review by Claire Wheeler, who led that. And we found that a majority of the studies, 9 out of 13, sure enough, found that crisis teams did reduce admissions. So most but not all studies found that. Picture's even more equivocal when you look at actual inpatient bed days rather than number of admissions. So some sort of caveats there really about how consistently or how definite we can be about crisis teams' impact on admissions. And similarly really with other outcomes as well. So most but not all studies which have measured patient satisfaction in a quantitative way found that crisis teams improve satisfaction compared to acute inpatient wards, but not all. When you ask people in qualitative interviews, service users by and large in general express a preference for being supported at home during a crisis rather than being admitted to hospital. So I think the kind of principle of home treatment in a crisis is something that people sign up to. But people have repeatedly expressed areas of dissatisfaction with crisis team care, more of which to follow. Concerns about risk management. So there's an increasing number of suicides happening in the context of crisis team care. That may well reflect nothing more that more and more people are being treated in crisis team care. So I think we don't know exactly how worrying that is, but it's definitely, I think, about 150 people a year die during crisis team care by suicide, which is a lot. And we know very little about other important outcomes, like how effective are crisis teams in reducing symptoms, in preventing readmissions to care. So some of our local data that's a few years out of date now from Camden and Islington found that about half of people who'd used a crisis team were coming back to acute care within a year. So they weren't doing all that one would hope ideally in terms of preventing crises of reoccurring. So to sum up then, I think we know that from the trial evidence that crisis teams can be an effective service model and are a sort of model that's really worth trying to make work well. But I think we also have to really acknowledge that the reality that crisis teams, there are likely to be crisis teams out there in the UK that despite all the resources put into them and the best efforts of staff are not having the effect of reducing hospital admissions or enhancing the experience of care that we would want. And I think in that context, there's a real kind of rationale for looking very hard at how they're implemented and how crisis teams can be made to work as well as possible. And I think what we know from a couple of surveys by Steve Onyett and colleagues in 2006, and a more recent one that our group carried out, is that there's a load of variation across the country in how teams are set up, and this was really the focus for the rest of our study. Okay, so I'm going to move on to the second question now about how might crisis teams work as well as possible. And just to sort of recap on what's involved in this, that all the stuff I'm going to whiz over where all this evidence comes from a bit. But we did do quite a lot of work really about looking at the literature, this national survey, which we got a great response rate with. So nearly 90% of crisis team managers gave up their time to tell us about how their team works. And over 100 interviews and focus groups with a variety of stakeholders, including people who use services, their families and staff. So what do we know? Well, there's actually surprisingly little empirical evidence about what are the crucial ingredients of crisis teams. And this is one of the problems with kind of trials and just studies of effectiveness. They might tell you whether something works or not, but they don't necessarily tell you why or how. But we did look for studies which had looked at sort of different models of crisis teams or looked about how variation in teams' care might impact on outcomes. And a couple of things which there's some evidence are important is one is longer opening hours. And that, I guess, stands to reason, doesn't it, really? If you want a team to be able to prevent hospital admissions, it's got to be there to do the assessments and offer an alternative. And having a doctor in the team seems to really help as well. And you can see why that might be helpful as well in terms of being able to manage higher levels of risk and perhaps the whole system having confidence in decisions not to admit if a doctor's part of that team making the decision. But that's about it in terms of what we know from quantitative literature. Where we do have some more guidance, I think, is when you listen to people who use services and who work in them. And there's actually really good agreement between the various kind of stakeholder groups about what people think matters most about crisis teams, what a good team looks like and what it should be doing. And by and large, the original guidance that came out in 2001 with the policy implementation guide when crisis teams were set up nationally is still supported. People still think that that's a pretty good model of care to go with. So I'm going to go into that in just a little bit more detail now, if that's okay. And this, starting off with really what service users and carers told us in the interviews we did for this study about what are the most important things that crisis teams need to be doing. And I'm just going to briefly touch on a few themes here. So rapid access, when people are in a crisis, they want help now, not tomorrow or next week. So ideally, people would like to be able to contact crisis teams themselves. If they have to go via a GP, they definitely would like the GP to be able to contact the team and help them to come to them. People don't want then have to go to A&E and wait again. The next thing, and I think of all the things, this was the thing that people said most consistently and most often, and it chimes very much with a theme that Stephen talked about in the first of these big sessions this morning in terms of youth mental health. And it's the same with adults, that what people say they really want is some staff who are kind and have some time to listen and to talk and to show care and concern. So people are not asking for something highly technical or expensive, but they want that kind of human concern and support during a crisis. Continuity of care. So one thing people told us they really don't like is in crisis teams with shift work and a team approach, it's often a different face every day who turns up at the door from the crisis team to introduce themselves. And if that does happen, if that's unavoidable, then what people would like is that the person who turns up on day 2 is cognizant of what you said to the different person on day 1, and you don't have to start from scratch again every time and tell your story and go back from the beginning at each visit. People also wanted continuity of care between services, so at the beginning about what's going to happen, and also at the end about what follow-on care is important. So this is where kind of collaborative care planning and the sort of work that Alan's done in the COCAP study is really important about trying to make that work well. Choice about types of treatment. So people didn't like when all that seemed to be on offer was a kind of fairly narrow medical approach. People did want help and support with medication, but they wanted more as well. They wanted psychological support or self-management support and help with practical problems and sort of social issues as well. And people, as well as that range, they wanted some choice from within that. So they didn't want to be told what their care was, but to be able to pick from a menu, really, of things that they would find helpful. And both family members and service users themselves told us that involving the family was crucial. And that stands to reason again, doesn't it? That if you're offering home treatment, the crisis team staff are not going to be there 22, 23 hours a day. And it's the family who are there to provide the support. So involving them and making sure they're supported and supporting the person in crisis is key. And I guess, sort of slightly dismayingly with my researcher hat on, perhaps you don't need fancy qualitative research to find this out. This is a Twitter account, #CrisisTeamFail. And this has some sort of fairly salutary reasons, fairly salutary reading, isn't it? But the kind of things, if you're able to see that on the screen, that people are picking up, is again, it's about actually being able to access a service when you need it, the continuity of people coming when they say they will, and the kind of quality of the interventions and the support that's on offer. There is a #CrisisTeamSuccess, I should say, which is more optimistic reading if you feel miserable having read that. Also worth sort of dwelling on what staff told us when we talked to them. So this is staff in crisis teams and staff working with them. I think staff generally endorsed everything that service users and families said, and they mentioned a couple of other more organizational things as well. So they talked about the importance of having role clarity about what the crisis team is for, and not just within the crisis team, but the rest of the system buying into that as well. And clear pathways sort of through care, so knowing who the service is for and how people are meant to access it. And they really emphasized the importance of services working together. So psychiatric liaison in A&E departments, inpatient services, and the community teams referring in, all having a good working relationship. And we were kind of interested in what staff told us tends to get squeezed when time is short and numbers are short. And this is what they said, really. So the things that sometimes don't get done as much as staff would like to are working with families as well as the service user. Any thought of beyond the immediate crisis about how you might look to the future and stop things happening again, or how you might respond differently in the future. And the duration of visits. So visits were just sometimes curtailed because there were so many to fit in. Okay, so from all that we learned, really, in terms of what people think is important from a good crisis team, this is our attempt to put it together, really. So this is the front cover of our core fidelity scale, which is essentially a wish list of kind of all the things you'd hope a really good crisis team would be offering and would be doing. And what we tried to do in this scale was to break it down into a number of areas. We've ended up with a lot of them. So we've got 39 items which cover things like how the team's organized and resourced, the content of the care provided, access to the service, and where and when help is provided. And for each of those items, we tried to be as specific as possible about what, from the research we'd gathered, a really good crisis team would be doing, what a sort of fair one would be doing, and what a team which really had room for improvement would be doing. And to be able to put a sort of score to those on a scale of 1 to 5. So we could use it as a kind of quantitative measure of kind of team fidelity or quality, with a range of scores there from 39 to 195. We wanted almost to put a 40th item in just to make the scoring nice, but that felt a bit indulgent, so we resisted. And we developed this kind of process for how we were going to do this. So we on the 75 team survey which we carried out, we went in for a day to teams, involved quite a lot of preparation from the teams themselves. But in that day, we tried to talk to groups of the staff working in the team. We interviewed the manager. We talked to key staff from other services like inpatient ward managers and community team managers. We talked to service users and carers. We audited 10 sets of anonymized case notes, and we looked at policies and the sort of routine data on things like how often supervision was happening from teams as well. We're quite confident about this scale in terms of, we know that it has a good range of scores. From the survey we did, we know that on each of our 39 items, we found some teams scoring high and some teams scoring low. And we did a sort of exercise to try and test whether different sets of raters could rate teams in the same way, and that also had some reassuringly good results. But I think some things we learned really in the process of trying to define what a good team looked like in each of these areas, and then also in assessing whether teams were doing these things, was that actually you have to really unpick the detail of what's going on in teams to kind of understand what's happening. So for instance, there's a real consensus. Everyone thinks that crisis resolution teams should be able to provide a rapid response. If somebody rings up in a crisis or a referrer rings up, the crisis team needs to respond rapidly. But how rapid is rapid? So we found that only 3% of crisis teams were actually assessing most people within 4 hours, sort of 90% of people within a 4-hour target. So there were a few teams that were really on it and were achieving that. More teams were assessing some people the same day. Less than half teams were assessing most people the same day, and there were a number of teams where it was kind of routine not to get to see people until the next day. So I think that's kind of quite interesting in terms of the 5-year forward plan that NHS England are putting together now, where they're certainly keen on an idea of a 4-hour response target. So I think a lot of teams are going to have to go some to sort of achieve that. There's also the fact that kind of headline data can be a bit misleading. So the mental health minimum data set are the kind of routine returns that trusts have to provide to the Department of Health. And they show that 97% of acute admissions are gate-kept by a crisis team. So they're really fulfilling that function of screening people before they go into hospital to see whether home treatment is an alternative. But when you talk to teams about what gatekeeping means, there is a world of difference. So for some teams, gatekeeping means actually seeing the service user in person, having a discussion about how they are and what's on offer and whether home treatment's a possibility. Other teams do gatekeeping via a phone call with a referrer. Some teams will gatekeep in person for voluntary admissions, but they don't turn up to, so that should be Mental Health Act assessments or Section 136s. And other teams will gatekeep most referrals, but not necessarily for some trusted assessors. So there are routes into hospital without the crisis team screening it via some areas. And some teams will count gatekeeping if they actually kind of review whether hospital admission is necessary up to a day after people have gone into hospital. Similar picture, I think, with at the other end of the sort of care episode, crisis teams, with making crisis plans and relapse prevention plans. So HTAS, the Royal College kind of quality improvement program for crisis teams, takes self-report data from teams about whether people have a crisis team and have a crisis plan by the time they leave crisis team care. And over 80% of teams say that this is done. But when we looked at kind of case notes and whether they were actually visibly there, we found really very few teams having a full crisis plan with all the things one might hope for in it, like identifying personal early warning signs of a crisis and triggers, what somebody's own coping responses will be, and what the service response might be. So I think you can see how that creates difficulties for commissioners or sort of senior managers in trying to really look at what a crisis team is doing and how it works well. And I think it does require buy-in from the whole team, the manager and the team itself, really, about what a good service should look like in order to make it happen. Here are a couple of slides that I'm sorry are probably too small to see well, but these are looking at, this one is from our national survey where we asked team managers what their teams do, and we tried to map some of the questions we asked managers about kind of crucial bits of the guidance from 2001 about what the Department of Health original guidance said crisis teams should be doing. And I think, without going into all the detail, that sort of headline at the bottom there is that there are almost no teams that are doing all the things that were in the original policy implementation guidance by the manager's report. And we found a similar story from our 75-team audit looking at team fidelity, whereas some things most teams are doing, there are a number of items, so looking there at the intensity of care, at preventing future crises, at rapid response, which are much more patchy. And I guess what these two slides show really is just that in terms of the kind of the crisis team model as envisaged, really is yet to be implemented as it was originally planned. So back in 2000, there was this, I think the NHS plan was a hugely bold vision for mental health care, sort of set up in when the 90s depression was over and we were entering a decade of boom and the Labour Party was still reasonably young and optimistic pre-Iraq. And they had this huge vision for EIS teams, for assertive outreach teams, and for crisis teams. And the kind of specification of what crisis teams should look like 10, 15 years on really still hasn't been implemented, only been implemented partially. And I think how nice it would be to sort of see what that vision would look like if done completely. And I think that's still something for us all to aim for. Just to pick up on a couple of kind of common challenges that we found across teams, really, as we were going along. And I think these are sort of things that all teams seem to struggle with, and they're perhaps inevitable tensions of crisis team care. So one is kind of how you keep a focus on really preventing hospital admissions and working with people who are the highest risk and most acutely ill and providing the intensive support that's needed to support people in that state of crisis at home. And what we found, I think, was that nearly all teams would recognise they have some people on their caseload who were not going to go into hospital if it weren't for the crisis team support, who are kind of having a really difficult time, having a sort of self-identified crisis, but not at the level that would require hospital admission. And I guess what that leads to then is the crisis team gets stretched, that they're providing a service to a bigger pool of people than originally intended, and are therefore not able to provide the kind of intensity of service one might hope for. So we found that only 12% of teams saw at least half the service users on their books every day for the first week of crisis team care. And if you think about a team that's trying to provide an alternative to hospital admission, really leaving people for kind of 48 hours without a visit during that first week of a crisis feels not safe, does it really? It's not the kind of intensity that I think I would want for me or a loved one kind of in a crisis. So that's a challenge, I think, kind of keeping to a tight definition of being able to provide intensive support to a really acutely ill population. And the second thing I think that is a sort of constant issue for teams is this balance about it's crucial that crisis teams do a thorough assessment, that they understand what's going on for people, and that they monitor things regularly like risk. But the balance between doing that and actually intervening and providing some care is something that I think is a challenge for teams. And we would certainly, when auditing case notes, you'd see an awful lot of diligent work, that people would have had a thorough initial assessment, a medical review, a risk assessment. Risk assessments might be reviewed as much as daily. You might have weekly care plan reviews. There'd be a discharge plan. And in that, you kind of look for what is the intervention? What's the support being offered to people? And sometimes that was not so evident. Whereas in other teams, you'd see a whole range of kind of help sorting out debts, manualized psychological interventions, sort of medication adherence things. And there's quite a sort of difference sometimes in terms of how much was achieved. And that's shown by some of the stats we got from our fidelity review. And a couple of trends. These are things that seem to be sort of on the rise. So one is that it seems to be increasingly common for the kind of crisis assessment, the front end of responding to a crisis and seeing what service people need, and then the home treatment functions to be separated out into different teams. So a number of trusts these days seem to be developing single points of access services which are separate from the kind of crisis home treatment team. And the Sunderland initial response team, I don't know how many people are sort of familiar with that, but it seems to be a kind of service that has really kind of caught the eye and seems to be an impressive model where they have this very well-resourced kind of crisis assessment, crisis call center, which can then go out and see people in a crisis and assess really rapidly, often in an hour or so, and see what service is needed and pass people on to home treatment rapidly if needed. So teams have set up single points of access to mirror this, but all the other ones we've seen haven't been resourced to nearly the same sort of standard that the Sunderland one is, and whether they're able to work as effectively, I think, remains to be seen. Open dialogue is another fashion that's kind of hitting mental health services generally, isn't it? And I think that's reached some crisis teams as well. So we're certainly aware of services down in the west of England that are piloting open dialogue approaches in crisis teams. And both of these may be fantastic ideas. They may not be. I think in terms of research, we've got very little current evidence either way to guide us. So what do we know about how crisis teams should work? I think we need to be honest that we know very little from kind of really, that we can say with cast iron confidence from robust empirical research literature. But there's quite a high level of consensus about best practice among stakeholders, and that mirrors policy guidance. I think we know that crisis teams haven't been fully implemented everywhere as intended. And I think what we found from our fidelity survey was really the picture we saw was not that there are some good teams and some less good teams, but it's just that crisis team care is this hugely complex thing, isn't it? That you have to juggle an awful lot, spin an awful lot of plates at the same time. And I think all teams were finding that all teams would have areas of strength, things they were doing really well, and other areas they were struggling with. And the challenge of doing this kind of complex care for a really varied group of people with crises that will be different from one another's is a challenge for teams. Okay, so last bit. How am I doing for time? Am I good? Yeah, cool, good. Okay, so crucially, I suppose it's all very well sort of thinking about where are crisis teams at, but the important thing is from where they are now, how can teams be supported to sort of provide the best service they can and to continue with service improvement? So I've got a few ideas from that, from what we learned on the research we've done. And the first thing that's crucial, I think, is investing in staff teams, in the crisis teams, and supporting staff to do their job. So I think the kind of reality of staff teams and crisis teams is that most people have come to a crisis team from acute wards, It's pretty rare for people to go from community teams where they're doing 9-to-5 jobs to work in a crisis team. So most people are coming from the wards. And I think the kind of experience of working in a crisis team and the things you're confronted with have a number of really important differences from the wards. So you have to kind of have the process of negotiating, engaging with people in their own home where they're not obliged to see you. You have to kind of really work with families and consider environmental risks where you have no control over the environment, and think about kind of positive risk-taking in that way. So there's an awful lot that's sort of different that you think staff would really value some sort of help and training in terms of this specific specialist crisis team role. And this slide is really just showing to what extent it seems to be being provided in teams at the moment. So most new staff joining a crisis team do get a sort of specific induction, so beyond the kind of trust generic induction, but they'll get a specific team induction. What that normally involves is shadowing staff who are already working in the team, which is a really great way to learn, and you see how the job's done. But I suppose it is dependent on what the staff are doing at the moment, whom you're shadowing. So you kind of need a sort of knock on a virtuous circle of good practice, don't you, to make that work well. Most teams, but not all, are providing monthly supervision to most staff. And where teams seem to be really squeezed in terms of supporting staff, very few teams have regular process. Well, about a third of teams seem to be having a regular structure for providing specific training in crisis team care to staff. And this issue of field mentoring, which is an Americanism really, but it's the idea about senior staff going out with practitioners in the field, either to demonstrate work and show you how you do things, or to observe people doing work and give some feedback, and that happening in a sort of structured, regular way and being tied into kind of supervision or appraisal processes wasn't happening so often as well. And we had some advice from American colleagues who are kind of implementation experts who said that above all things, that seems to be associated with successful implementation of mental health models, and showing people how to do things in practice and giving feedback in vivo really helps. So that's something I think that would be great if it were done in a more widespread way. Multidisciplinarity is another thing that no one can be an expert in anything, isn't it? If you want kind of social workers or support workers to know how to do side effect schedules, it's good to have some nurses in the team. Likewise, if you want people to be able to assess ADLs, it's fantastic if you've got an OT in the team to give you some guidance on that. So the more multidisciplinary teams are, I think the more opportunities there are for sharing skills and knowledge, and that varied quite a lot in crisis teams too. So supporting staff, one thing I think that might really help with service improvement. Sharing good practice, I think, is another one. So it can feel like quite a luxury, I think, in a busy, stretched team to take time out to sort of chat to colleagues in other teams or go and see what's happening in another trust. But kind of finding ways to kind of share good practice seems to be something that really doesn't happen a lot in teams. I went to a sort of planning meeting of the Royal College Home Treatment Accreditation Scheme a couple of months ago, and there was only sort of 12 people there representing about 6 trusts, and in 3 of them they were developing local suicide prevention training. And you kind of figure that what a shame, you know, really, that if they could have been in touch with each other, either 2 trusts could have not done that work and borrowed the other trusts, or they could have collaborated and made it tip-top training, really. And that opportunities to kind of really pool resources and expertise and good practice, I think, should be really cherished. So the first thing there, our core crisis team resource pack was our attempt to sort of provide a structure that can do that. And wherever in our survey going around the country, we found teams that seemed to be doing things really well. In good Magpie fashion, we asked to sort of use their resources and put them in our online kit and show them as sort of examples of good practice. And that's something that's publicly available now for teams to access. And we've also tried to put in policy guidance and testimonies from service users and things that will kind of help develop resources. Royal College's HTAS scheme is another attempt to do that, and they have a kind of, one of the best things that you get from joining up from that scheme is not just their reviews, but access to this HTAS chat, where if you've got a question about how things might work in crisis teams, you can put it online, and hopefully there'll be another team that's been through that process and might have some helpful guidance for you. And the Crisis Care Concordat are trying to do that on a national level with their kind of inspirations online. And it was great this afternoon to hear about the kind of knowledge bank and the Middlesex scheme that Carmel Clancy in her talk was talking about, which was really an attempt to get that together at a local level, I think, really for all the resources and skills that are in teams to be as accessed and shared as possible. And last thing, I maybe would say this having developed a kind of audit process for crisis teams, but what we heard from the teams in our study was that actually they really valued the kind of what the fidelity scale gave them above all. It didn't matter so much about the score. It was like having a clear model about, okay, this is what we're aiming for. This is clearly what we do. And even if there were things that teams sort of decided they couldn't do because they were impractical, or in a few occasions teams actually thought, well, no, that one we don't agree with. It gave teams an opportunity and a sort of structure for thinking about, well, what is it we're doing and why, and to have a kind of clear direction of travel. We hope actually some sort of feedback about service improvement was useful to teams as well, and teams told us that. And I think if possible, evaluations should involve an external aspect so that you've got people with an objective eye coming in. It certainly involves service users and families' views, and look at case notes to look at what's really going on rather than what is the sort of wish list for teams. Okay, so we've tried to put a program together that we hope might be helpful for crisis teams in our cluster trial now, which has involved access to this online kit, but also a kind of coach with half a day a week who's an experienced clinician to go in and help teams with developing service improvement plans. We're trying that out, and results, as I say, to come later in 2016. What I can do is share a little bit of the process data from this, though. And so here's one slide with a couple of things we found. These were the kind of changes in the actual our fidelity score in teams at the beginning and end of the service improvement program. So if you look at the columns on the left is our control teams, 10 control teams. And actually in the context of a kind of year of austerity with funding being cut and demands going out, none of those 10 teams managed to sort of improve their fidelity on our audits during the course of the year. Whereas in the intervention arm, not all but most of the teams did. So the red scores are the positive ones that went up, which gives us some hope that the package of service improvement we were offering teams was useful to helping them develop their service. And this was a graph that gave me great pleasure, this one. So this is looking at the relationship between our fidelity scores and service user satisfaction on the CSQ8 measure of satisfaction. And what this is finding is that there is a positive correlation. So as teams improved in their sort of fidelity on our measure, service users were also more satisfied with the care they're receiving, which gives us some sort of confidence that we're measuring the right things. Okay, so just to round up, here's our kind of a plug for the two resources really that we hope will be helpful for crisis teams that we've developed in the core study. This is the fidelity scale. On the last slide, I've got the kind of web links to both of these. They're both publicly available. And this is our kind of online resource kit, which for all of these 39 items we had in the scale, we've tried to give some helpful stuff that might be a sort of starting point for teams in developing services. Just to flag up, I think there's sort of changes afoot in terms of external drivers from the NHS England and the Department of Health. We're doing a small piece of work for them now, repeating our kind of survey of crisis teams to try and give them some baseline data, and they're particularly interested in a few key issues, one of them being this issue of how rapidly teams can respond, and they're interested in this, whether teams can hit a 4-hour target for going out and assessing people following a referral. So I think there will be sort of pressures to develop services, especially around access. Our funders, the Department of Health through the NIHR scheme, would like it to be known that anything foolish I've said today is my fault and not theirs. Thank you very much indeed. Thanks.
Thanks very much, Bryn. That was a really fascinating sort of high-level overview. We do have 2 or 3 minutes for questions. Leisha.
Hi, thank you for your presentation. I'm Leisha Rennick from the University of Manchester. Your presentation was really interesting, and I suppose what struck me was, because my background is in early intervention in psychosis, that the program or the implementation guide in 2001, both crisis resolution and early intervention in psychosis were named, and what I found absolutely striking was how far crisis resolution is lagging behind early intervention. And I don't know a whole lot about crisis resolution, but in 2006 there was some massive fidelity exercise in early intervention, which found that there was much higher rates of fidelity to the model and to the implementation guide. Subsequent fidelity exercises have shown the same, but then there was some lobbying again after 2010 because of problems with funding and like receding funding, and massive audits from HEE and the Royal College of Psychiatrists, which has resulted in access and waiting time standards and other policy documents. And I see that only kind of starting now with the crisis resolution. And I don't know, would you like to maybe say what you think is going on there? Because it's really stark how different their paths are, even though the policies were developed in the same year, in the same document.
Yeah, thank you. I think there are sort of at least a couple of things going on. So that the starting point of the guidance from the Department of Health, which I think by and large was great, but there's a kind of level of detail which wasn't in it really, which then needs to be worked out by teams. And I guess kind of perhaps a couple of things that early intervention for psychosis services have had that crisis teams haven't is, one, I think there have probably been more sort of structures in place to sort of help provide that detail and to develop services. So things like the kind of IRIS initiative in early intervention, I think, are fantastically helpful for sort of team planners and managers thinking, what should my service look like? And that's not been there, I think, right from the start for crisis teams. Yeah, I think perhaps the other thing is just that there's a really defined client group and perhaps a more defined set of evidence-based interventions for early intervention in psychosis teams, whereas crisis teams, knowing what you can do over a brief period of crisis with a hugely disparate client group is tough, really. So sort of the trying to have a clearly defined model is perhaps an even bigger challenge in a crisis team setting.
Okay, well, thanks very much, Bryn. Thank you.